I just don't know WebEx well enough. I'm afraid to hit any buttons or touch anything because I'm so used to being on Zoom. But I look at this and go, it's just not as familiar to me as Zoom meetings are. I'm afraid I'm going to.
Okay, we're going to get started now.
Okay.
Good evening. I'd like to welcome everyone to the COVID-19 vaccine, Facts Not Fear, Vaccine Safety Webinar for Healthcare Professionals for December 17th, 2020. My name is Donald Moore and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format is 45 minutes of moderator-asked questions of the expert panelists and 15 minutes of Q&A from attendees using the chat functionality. Attendees who join by telephone who have questions should ask their questions, send their questions to epnrtraining@vdh.virginia.gov. Your feedback is requested regarding the panel discussion webinars. Please complete the survey. The link is provided in chat. Unanswered questions will be collected and answers provided in a FAQ document. Your expert panels for the evening are as follows. Dr. Lillian Peak, Director of Epidemiology, Virginia Department of Health. Dr. Kosti Sifri, Professor of Medicine and Director of Hospital Epidemiology, UVA Health, Division of Infectious Diseases, Co-Chair, VDH Vaccine Advisory Work Group, Safety and Efficacy Subgroup. And Dr. Richard Wenzel, Emeritus Chair and Professor of Medicine, VCU School of Medicine, Division of Infectious Diseases, Editor-at-Large, New England Journal of Medicine. Your moderator for the evening is Dr. Lisa Ellis, Associate Professor of Medicine, VCU School of Medicine. I'll now turn it over to Dr. Ellis.
Thank you so much. I'm glad to be here this evening. I think before we start with our questions on vaccines, I think it's probably good for us to kick off looking at some of the numbers that we have and the implications that go along with those numbers. Looking at this country having over 17 million positive cases and well over 100,000 hospitalizations, and again, sadly enough, well over 300,000 deaths. Dr. Wenzel, can you tell us a little bit about what you think the implications of these numbers might be?
Yeah, so first of all, I would say there's nothing to celebrate in the numbers that we have now. Some of them really point to some significant thoughts that we have about public health. With over 100,000 hospitalizations nationally, we are at the breaking point for the medical care. You can't turn on the news, read a newspaper without hearing about hospitals, particularly in the north central part of the country, out of beds, out of capacity to manage critical care patients. And the next 2 months or 3 months are going to continue to escalate, particularly related to the holidays. So that's with hospitalizations. With over 200,000 new cases per day, what I can tell you immediately, the implications for health is any kind of contact tracing program is out of the question. These numbers preclude contact tracing. You can imagine if you had 200,000 people, 10 contacts for each, 2 million cases to contact per day, that's out of the question. And so what you're going to see is state by state, more and more doing what's going on, for example, in California, calling for major shutdowns. Targeted issues maybe later on, but not with these numbers. With over 300,000 deaths, what we've learned in the last couple of weeks is that puts the number one cause of death in the United States with this virus, COVID-19 disease. Number one cause above heart disease, lung disease, cancer, neurologic disease, all within a year are number one cause of death. This has really had an impact. We're in trouble.
Yeah, quite the implications with really astounding numbers. To set the stage of the importance of this vaccine, can you talk a little bit about the process for a vaccine in trying to obtain herd immunity and maybe how long a process like that might take? Dick.
Well, first of all, just to make sure we're all agreed that it's herd immunity is the proportion of the population that's immune that will prevent transmission of the virus. And for this virus, we need 70% of the population. So roughly, just so we can kind of imagine the numbers, 200 million of the 300 plus million people living in the United States. Now, to get 200 million people immune, we're going to need 2 doses each, so 400 million doses of vaccine. But so the first thing is you need available vaccine that's efficacious. The efficacy we can actually feel good about today. We have 2 vaccines, Moderna and Pfizer's, with 95% efficacy protection. In terms of availability, we have, as a country, made a deal with Pfizer for 100 million doses, with Moderna, which was approved by the external committee today, 200 million doses. And then with 4 or 5 others, including Sanofi, AstraZeneca, Johnson & Johnson, and others, 810 million. So we'll eventually get there. It's the rollout that we really have to face. By late spring, perhaps 400 million. The real challenge is the next issue, and that's acceptability. For example, if just to make it easy for people to calculate in their own heads, imagine a vaccine with 90% efficacy and 50% of the people in the country willing to take it. 0.9 times 0.5, that's 45% immune, well below the 70 to 60% that we need, plus the 10% already there from infection. So how do you get above 60 million? You need a vaccine at least 90% effective and times 70% of the people willing to take it. 9.9 times 0.7, 63%. Plus the 10% we have, that would get us over 70. The problem is the Pew Research says that at the current time, only 50% of the country is willing to say they will definitely take the vaccine. We really have a challenge ahead, and that's the key one, I think.
Yeah. Dr. Sifri, when we're looking at people being hesitant with this, some people are really concerned with how these vaccines were approved so quickly. Can you tell us about this process and how we were able to move this so quickly?
Yeah, thank you for having me tonight. I think that's a key thing that I think we can help with our patients to provide that understanding of how the vaccines, it's plural, how these vaccines are going through development and through the regulatory process to now being used clinically. The first thing that I like to highlight is the fact that these vaccines have not have really been based on a decade or more of important research. So, the understanding of the importance of the spike protein, the S protein, in terms of protection against coronaviruses, initially SARS and then MERS, have been made over the course of a decade. And so we understand it's an excellent therapeutic target to develop an effective vaccine. And that really needs to be highlighted. While SARS-CoV-2 is a novel virus, the understanding of the pathogenicity of coronaviruses predates this. So we had a good head start. The second thing to understand is that really in the last 5 years or so, we've really developed some really robust platforms for the development of rapid vaccines. So we'll focus right now on the messenger RNA vaccines. Those really are coming to the fore here. While they've been based on several decades of research, the stabilization of mRNA, the delivery vehicles and this lipids, that really is new technology. So to be able to go from the publication of a draft genome on July 10th to the production of a vaccine that one could be used in clinical trials, which is in 66 days, which is what occurred with the Moderna vaccine, is simply astounding. However, the processes of going through from draft genome into this platform, into clinical trials, still all the normal steps of a clinical trial were performed. So phase 1 clinical trials, it's important to say that the preclinical trials were performed, phase 1 standard clinical trials in terms of safety and the initial understandings of immune response, and now phase 2, 3, which is what we're seeing now, those clinical trials have all been met. So the other important thing that I like to highlight is that the clinical trials have been performed under the umbrella of Operation Warp Speed. The problem is, a problem with that, of course, is the name Operation Warp Speed. I think that has unfortunately led to a lot of discomfort amongst many people, I think even in the medical community, about this development. And that's unfortunate. But I think the structure of Operation Warp Speed was good. So using multiple clinical trial networks, stitching them together, putting them under one umbrella with one funding resource, and this public-private partnership really helped accelerate the development of these vaccines, put them into parallel clinical trials where they had the same outcomes, they had the same Data Safety Monitoring Board, DSMB, independent review of the clinical trials performed at the same time. And what we'll see later on is the surrogate markers of immunity, all measured in the same labs, that we will be able to do comparisons of these vaccines between each other's once we collect all that information. The next important point then, of course, is that we had a pre-purchase of vaccine before we knew the results of the clinical trials. So manufacturing was gearing up, factories were retooled, the production lines were put into place so that we would have vaccine on hand once the clinical trials were done. And we're living in that era right now, right? So if we had not had this process, we would be seeing EUA authorization occur, the recommendations for use occur, and then we would be then waiting several months for the production lines to get going. But that's not the process. Within several days of EUA authorization and then ACIP, the CDC's review committee recommending its use, it was on planes and on trucks being sent to hospitals. So I think that's really the important point. The corners weren't cut, but the intermediate steps, taking a look for funding, taking a look for the next steps of development, those were the parts that were taken out of this process.
So you think those were the risks that we have with going from the emergency process to something that would be full approval?
Yeah, so the differences between an EUA and a full licensure, the biggest differences between these processes is the duration of follow-up. So the clinical trials that we've heard about with Pfizer, with about more than 43,000 participants, and with now Moderna's vaccine with 30,000 participants, those are every bit as large and larger than many of the other vaccine trials that have led to vaccines that are now on the market. So the large difference really is the duration of follow-up. So we have 2 months of follow-up with these vaccines to assess their efficacy and their safety. And that 2 months is shorter than you would anticipate in what would be required for licensure. So these are temporary. When we have full safety information from a longer period of follow-up, about a year, then we will see these vaccines, presuming they continue to have the excellent efficacy and safety that they have right now at 2 months, we will see them move to full licensure.
Sounds great. Dr. Wenzel, let's switch gears and go back to the mRNA process and talk a little bit about the mRNA vaccine process and how that might relate to the storage methods with the ultra cold storage.
Yeah, well, it's important to know that mRNA is very fragile, single-stranded gene, and it has the ability to break apart and be subject to a lot of enzymes. So what the chemists have done, first of all, is actually add carbon bonds in the mRNA to begin to stabilize this single-stranded piece of gene. And then secondly, because they know to go through the body where we have lots of enzymes that will attack nucleic acid, they've encased this material of the mRNA within a lipid nanosphere. So it's like a covering on the outside. Imagine an M&M with the mRNA being the chocolate and the shell, if you will, of the M&M being the lipid protector. And then what they've done is add a number of chemicals to make sure that the pH is the same as well. And that's within one of the lipids. And the other thing they've done is actually say, we're going to keep it in the cold, just as you keep food from being spoiled. So they have to have this in the cold. It's quite different, minus 70 degrees centigrade for Pfizer's, more like a freezer for Moderna, minus 20 degrees centigrade. And the differences are a little bit unclear how we got there. And the lipids are pretty much the same in both, but 2 out of the 4 lipids are different. Whether that makes a difference, it's a little unclear. So it does challenge people to imagine all the work that has gone into this, but it's responding to the particular fragility of the mRNA.
Mhm. So how long can they be stored, and what about how they're being transported when you have to use this kind of storage process?
Yeah, great question. So it looks like in the frozen condition, 6 months is probably the minimal shelf life. It's probably going to turn out to be longer than that. Once you bring it into the refrigerator, for sure, the Pfizer and I think both probably have 30 days. And then once you put it on a table in the room at room temperature, you have hours. I think probably up to 12. But what the companies are saying now is after you have it all there, if 6 months go, 6 hours go by, 6 hours, then toss out what you don't have. And so what you're hearing is if you have to organize this, if any's left over, they're looking around for people to use it on because we might have these extra things. And then in terms of transporting, you have to have ultra low refrigerators for transporting this from the plane, to the pharmacy or to the hospital, wherever they're going to deliver that. And so these are instruments that, cost somewhere between $12,000 and $20,000 to keep, particularly the ultra cold Pfizer vaccine at a -7.
Oh. So Dr. Peak, tell us about our status in Virginia with adequate number of ultra cold freezers and how that's coming into Virginia and where these locations are that this is being transported to.
Sure. So at the end of November, we reached out to health systems across the state to determine who had ultra cold freezer capacity. And we do have adequate capacity across the state. Many health systems do have that capacity. And so for the initial Pfizer vaccine that came into the state this week, it was shipped to 18 facilities. And some of those are serving as hub and spoke models. And so it's gone out to many more than 18 facilities. So we do have that capacity. And also there's a federal long-term care facility partnership with CVS and Walgreens to help vaccinate residents and staff in long-term care facilities. And they have, CVS and Walgreens also has that capacity and has been developing the capability to handle the vaccine and getting all of those processes in place.
Great. So now we're getting it into the state. Can you talk to us about the process of actually getting it into the arms of people and what that tier process looks like in Virginia? Dr.
Sure.
Peak.
Okay. So I'll talk about the process for the groupings. And because, what Virginia is doing is we're going to adopt the CDC's Advisory Committee on Immunization Practices recommendations. And if within those groups, if there's sufficient amount of vaccine for the entire group, then we just ship the vaccine to the providers, to the vaccinators. If there isn't sufficient vaccine, then our vaccine unit, which is part of the Virginia's Unified Command, will make recommendations for sub-prioritizations. And then we have an extensive vaccine advisory work group with over 100 members with all backgrounds, very diverse group. And we will send our recommendations to that group for comments. We'll then send our recommendations and all of the comments to Virginia's Disaster Medical Advisory Committee. And this is a group that was set up to make decisions about scarce resources. It was set up in the spring when there was concern about healthcare capacity, and that group has continued to meet. So they will then make recommendations to Virginia's Unified Command. That's actually already taken place for the phase that we're in right now, which is called Phase 1A. ACIP recommended that healthcare personnel and residents and of long-term care facilities be the first group. And so our initial estimates for vaccines are close to what that entire group is, but they are just planning estimates, and we are still waiting for actual numbers to come out from the manufacturer. So the VDMAC, as we call it, that committee did put in levels for different groupings. And the first group is healthcare personnel who directly engage in the care of patients. And then the next grouping is personnel that interact with patients that are at higher risk for infection based on, like, for example, patients who are in a long-term care facility or EMS workers. And then the next group are other health system employees that are in clinical roles or very critical operations for the healthcare system to function. And then that fourth grouping is all other healthcare personnel who interact with patients who aren't known to have COVID. And so those groups are in place. Additionally, ACIP actually recommended groupings for the long-term care facilities. And so the first group is nursing homes, the second is assisted living, the third is residential care communities, then intermediate care for individuals with developmental disabilities, and then state veterans homes. So the VDMAC said that, those are the groupings, but it's not, really, it's not like hard lines. We want to make sure that vaccine gets in arms as quickly as possible, and we want to be practical about that. So no vaccine sitting on the shelf, but try to follow those groups as much as possible. And then as far as who's doing the vaccinating, it's healthcare systems and also public health. And then I already talked about our partnership with CVS and Walgreens.
It's quite the complicated process. I'm sure it's all listed somewhere on websites, so people can go and look and see on the VDH website all that information. It's hard to keep it all straight. Dr. Sipri, when we're talking about getting it into the arms of people, do you think, let's talk about some special populations. Should children receive this vaccination, and what age would we be talking about with children?
Yeah, I was just going to comment that I thought my job was hard, but just hearing Lillian's recitation of the order, impressive, and what a challenge. So children, that's a very good question. So with the Pfizer vaccine, which I think is the one we're talking about that is available right now, so it is licensed to children as young as 16, so 16 and 17 years of age, and so we don't have efficacy information on that subgroup, but the safety appeared similar to all the other age groups, so very safe. I think clinical trials are underway right now, taking a look at the Pfizer and I think also the Moderna vaccine in younger populations in the 12 to 15 age range, and I think future plans will be taking a look at yet younger ages. So those are in the works. But right now, though, they are not recommended for children.
What about vaccinating pregnant women or even healthcare workers that are pregnant?
Yeah, I think this is a really important issue. It's one that we're going to have to really talk about especially within healthcare. Now, as we expand across all populations, this is really important. But since 75% of healthcare providers are women and many are of childbearing age, this is a really important issue. And I think the guidance that was provided by the CDC's interim guidance is important. They basically encourage a conversation with your obstetrician or your primary care doctor to talk about these issues. But I really think that if you take a look at that guidance and others and guidance from professional groups like the American College of Gynecologists, they really are noting that it's a risk-benefit calculation that must be made, understanding the significant risk of COVID to pregnant women. While numbers are small, it is a real and important cause of significant morbidity and mortality in pregnant women. So not particularly common, but is now a preventable infection, and to balance that with the risk. And the understanding of the risk is difficult because the clinical trials did not include pregnant women. So that's going to be an issue that you need to have a discussion with as a provider. Now, I believe there were a total of 21 women that were in the Pfizer vaccine study that were not pregnant, but became pregnant or were found to be pregnant during the clinical trial. And there was no signal there of any harm, but that was not a formal part of the analysis. And so the final thing I think that's probably helpful when we're talking particularly with our health providers who are pregnant is to understand what the vaccine is, particularly the messenger RNA vaccine. So I think Dr. Wenzel provided a very good overview of what it is. So this is messenger RNA, a very unstable, made slightly more stable piece of messenger RNA, a coding segment for protein synthesis. It is, it's being, taken to the ribosomes through the trafficking of through the cytosol of the cell. It is not going to the nucleus. It's not going to interact with DNA and cause genetic mutation. It does not contain adjuvant except messenger RNA as an adjuvant if it is. So, it really would not be something that we would anticipate or predict would cause genetic mutations, which I think is going to be the most significant concern amongst most pregnant women and lactating women as well.
Right. So, Dr. Sifry, would you say the same about immunocompromised patients or people who are on, immunosuppressing drugs?
Yeah. So I think that the same issue. So again, populations that were not studied in the Pfizer or the Moderna clinical trials. So efficacy is difficult to discuss. Safety, we would predict, should be as safe. And what we do understand is those populations are at high risk for infection. That there are patients that had stable HIV were included in the Pfizer vaccine. So we have some subgroup analysis of that. But importantly, again, these are populations that are high risk for COVID infection. And I think what we will be seeing now with phase 4 studies is taking a look at the clinical outcomes. Most of the providers that I know that take care of patients in this population, I'm including myself because I also run an immunocompromised infectious disease program here at UVA, looking at transplant patients and patients with acute leukemias. I think that we'll be also assessing this in a programmatic way. And it's a big discussion point in our community. The only other one that I would also discuss, I think I actually saw this in the chat, is I think the concerns about patients with inflammatory conditions. So rheumatologic problems or other things that are on specific immune suppressants with that. And I think some of the concerns of those patients who are concerned that a vaccine could accelerate or accentuate their disease. And again, American College of Rheumatology has said, this is again a conversation you should have with your allergist and your immunologist to see what the risks and benefits are. Take into account things like the unknowns of what the safety and efficacy is in our particular patient population, but also the known risk for infection. Maybe combined also with what's occurring in your community in terms of the amount of disease. And probably on balance for most patients, the benefit of vaccination is likely to outweigh the risk, even with these unknowns, recognizing that infection due to COVID is a highly inflammatory condition. And so, we see some of the highest inflammatory markers due to acute infections of infectious diseases in COVID-19 compared to many others. So at least on balance, my recommendation would be consider that when making discussions about vaccine.
Sure. So Dr. Wenzel, you mentioned that Moderna has gone through today. And so what do you think it makes a difference if people have the Pfizer vaccine for the first one and the Moderna for the second one? And what the differences will be since they're both?
Well, I think we could say the difference will be very slight in terms of efficacy. They're both 95%. They're both very safe. And all the subgroups in both vaccine look to be protected. So even obesity, which can sometimes be a problem for getting an immune response to a vaccine, again, it looks like it's also 95% protective. So the subgroups, Kasti was talking about some of them, again, they all look protected. The numbers are small, which makes it hard to say, okay, if you're immune suppressed or pregnant and so forth. So I think they're safe and efficacious vaccines. What I would say in terms of if you got the first vaccine and it was Pfizer's vaccine, I would try to stay with the protocol as much as you can. Get the Pfizer vaccine, 3 weeks later. If you got the Moderna when that's coming out, probably next week, then, a month later, get the Moderna. My guess it would be with both mRNA vaccine, it probably wouldn't make a huge difference, but I would stay with the protocol because the protocol defined what we know, what worked, what the side effects were.
What is the difference between the initial vaccine and the second or booster vaccine?
In terms of protection, it certainly it looks as though you get maybe 50% or more with one dose. After the second dose, within the first week, you're up to 90, and after 2 weeks after the second dose, you're up to 95%. The adverse effects are more with the second dose, and people are talking about look, it can make, there's a lot of fatigue. Most of the adverse responses, whether it's fatigue or headache or myalgias or arthralgias, are graded as mild, but there may be some people who will want to take off a couple hours from work the day after. You might think about that with the second dose of people, but there are some more side effects.
Sure. What about the timing? You know, there's some vaccines that we start with the first one, and if you don't get the second one in the right amount of time, you have to start over and do your first doses again. At what point would we need to be thinking about that? Because this is going to be a complex process, I'm sure, as we're getting going with the second vaccinations with people.
Yeah, well, what I would say is, look, if you're off by a couple of days, that's not going to probably be a big deal. If you're off a month, 2 months, 3 months later, we probably need to talk, because we'll sit down and, do you start over? You just had a second dose. And without having any information yet, I would probably be inclined to start over, but people could argue with that. It's going to require a discussion.
Sure. Dr. Peak, can you tell us a little bit about the process that will be documented for when somebody is actually vaccinated here in Virginia, and what kind of documentation we need to have for when a vaccination occurs?
Sure. So it is required that people enter the vaccinations into our Virginia Immunization Information System, so our registry in Virginia. And so the information will be in there, and that's important because they then will be able to track what type of vaccine people had and when they need their second dose. At the time of vaccination, in the kit that comes along with the vaccine, there's actually a vaccine card. So people will be given a card and also encouraged to take a picture of the card so that they have it in their phone. So that's a backup as well.
So how do people at the location specific need to keep all that documentation, or will we have that centralized so that we'll be able to go back to it when we need to?
So when you enter the information for the patient into the Virginia Immunization Information System, that information is accessible to you. And to all providers. So that is it's a vaccine registry that we have in Virginia, and that's where the information will be entered.
Okay, just like our other registries.
Yes.
Dr. Sifri, tell us a little bit more about the side effects that we should be aware of with first and second. Dick started to allude to them with fatigue and myalgias. What other side effects do we know about?
Yeah, so a couple words about side effects. As Dick said, most of them are mild and quite tolerable. They tend to be a little bit more accentuated with the second dose of the vaccine compared to the first, and also a little bit more robust in younger persons compared to older persons. But most of them are, especially with the first vaccine, are not going to be that much different than like a flu vaccine with local tenderness and discomfort at the site of injection, usually lasting a day or so. What has been reported, again, more with the second dose of the vaccine is fatigue, headache, muscle aches, myalgias, in some cases some chills or low-grade temperatures. So again, as Dick alluded to, after the second dose, particularly if you're younger, that may be some counseling to say for some people you may need to think about whether you need a couple hours of work off the following day, and that's really the predominant side effect. As described in the clinical trials and as Dick had talked about, severe adverse events were rare. They were equally proportioned across the groups, and so they are uncommon. But if you wish, then I think we could also talk a little bit about issues concerning some of the post-marketing side effects that we're seeing in terms of allergy, severe allergy.
Yes. And so how should people screen for allergies? And a lot of people in the Virginia area have allergies. And so there's a lot of talk with allergies. And what do you think we should screen out for that?
Yeah, well, so again, going back to the clinical trials, they did not see that there were significantly more severe allergies in the vaccinated group compared to this placebo group. But there, of course, should be a note that patients with severe allergies and a history of anaphylaxis, for example, were not included in the clinical trials. And what was seen, in the UK early after its use was that there were 2 nurses who had a history of anaphylactic-like reactions who carried EpiPens that ended up reporting anaphylactic-like symptoms that were treated with Epi without a problem. Now, because of that, and because I think this is still a bit unknown, there is now guidance on how to approach patients that have a history of having severe allergies. So the first thing in terms of strict contraindications, the only contraindication right now in that regards is patients that have had a history of anaphylactic reaction to COVID, to the COVID vaccine that's being used, to the Pfizer vaccine or its subcomponents, which again Dick alluded to are these new lipids or the messenger RNA. So in essence, the only contraindication in terms of an allergy is a previous reaction that was in the anaphylactic spectrum to the first dose. Precautions are suggested for patients that have a history of severe allergies, anaphylaxis, and the like to injectable medications. Again, that the recommendation is to have a conversation with your provider. That is going to, again, be similar to what I talked about before, where there's a discussion about the potential risk versus benefit of allergies. And for those who get a vaccine, and we're having those conversations with some of our providers that have that history, recommended follow-up for 30 minutes after the vaccine to just make sure that everything is okay and to be prepared to provide the vaccine and again, be ready to be able to respond should something happen, should somebody have a reaction.
So anything that you suggest that people do for mitigating this, and also what the caution might be with using NSAIDs prior to?
So good question. So what are the cautions like? Should there be pre-medications with antihistamines or NSAIDs? And we really don't know how the vaccine would respond if people are pre-medicating themselves. So currently the recommendation is to not pre-medicate with those medicines, but that after vaccination, should people have issues like that, like pain, discomfort, that those medications can be used post-vaccine.
And Dr. Wenzel, anything else with NSAIDs that we would want to be careful of with the use with the vaccine?
No, I mean, just to go back to the vaccine, if you're allergic to eggs, this has no egg in it. I would say that has no preservative in it either, such as thimerosal and earlier vaccine. People worried about its link to autism. It's not even in there. And for the conspiracy theorists, by the way, there's no microchip in this vaccine. So what do you say? What's in the vaccine that might make you allergic? Well, the mRNA, we have no idea. Any one of the 4 lipids, the salts, it seems unlikely, sodium chloride or phosphate buffered saline. And then they both have sucrose. It's a cryoprotectorant, which helps keep stability in the very cold. The one thing that I would say I would keep my eye on is one of the lipids in both vaccines has polyethylene glycol. And there have been reported allergies to polyethylene glycol, including rarely anaphylaxis. So I would just alert the allergists out there, give us a hand if we see these kind of patients. And I think what Kosti said is, look, be prepared to bring the epinephrine in and whatever the rescue meds like Benadryl, steroids that you might have the patient stay around. But I think it'll going to be very uncommon. And I would tell people, even if you have an severe allergy to penicillin, there's no penicillin inside. Go through the ingredients. Look at the ingredients, mRNA, the lipids, the salts, and the sucrose.
Sounds great. Dr. Peak, what about the adverse effects? How will we be monitoring that here in Virginia? And can you discuss like the V-Safe program or the VeersOn program that we might be using with that?
Yes, so we have good federal programs to monitor the safety of vaccines. And so we're going to be utilizing those programs. So it's the Vaccine Adverse Events Reporting System, VAERS. There's also two other systems that it's a network of different clinical providers that the data are collected from and looked at by CDC. So there's the Vaccine Safety Data Link and the Clinical Immunization Safety Assessment. So those are what we use for all vaccines, and those will be utilized. But CDC also developed a new tool. It's voluntary, and it's a smartphone-based tool. It's called V-Safe. And what it does is the patient signs up, and they're sent a text message that then takes them to a web survey, and it's just asks them some very simple questions about how they're feeling. And so that's a way for CDC to actually do a little bit more active surveillance or really trying to ask people to report on how they're feeling. The nice thing about that too is it also gives you a reminder for the second dose. So those are the systems that we'll be using. And then also they stood up a COVID-19 vaccine safety technical subgroup, and they're going to be reviewing the vaccine safety data as well. And so if there are potential safety issues, CDC and FDA will work closely together to rapidly assess the situation.
Great. Dr. Wenzel, what about some of the other vaccines that are on the horizons? What can you tell us about like the AstraZeneca, Johnson & Johnson, or some of the other things that are coming up?
Well, AstraZeneca published some of their early data and remind you that this is not an mRNA vaccine. The platform AstraZeneca has is an adenovirus that has been engineered to contain the code that'll actually make the spike protein. They happen to use a chimpanzee virus, which should be harmless to people. And in addition, it's a virus that is not going to be able to replicate. So we're not going to see a rogue adenovirus take over at any time. The odd thing is, when they reported the data, they made a mistake partway through. And on some of the patients, instead of getting 2 full doses, some of them got half a dose first and then a full dose secondly. Well, you'd say, well, did that matter? Maybe you learned something. Well, the weird thing was if you had the half dose followed by the full dose, you had 90% protection. If you had 2 full doses, you had 62% protection, and it averaged out to be 70. And you sort of have to ask them, how do you explain why you have a better immune response with less of a dose? And there are a couple of theories out there. One, the statisticians say, well, it's just too early. Pretty soon they'll start to merge. The 1.5 dose will come down, the 2 doses will come up. The second, that's out there is, well, maybe there's a T cell subset that actually facilitates B cell production of antibodies with a lower dose somehow that you don't see. Well, that seems pretty speculative to me, but we'll see what else. The third is really fascinating. There's a group out there saying, what's happened maybe is that with the big dose, you make so great an adenovirus antibody response that it blunts the spike protein antibody response. Well, the good news is we'll be able to measure antibodies both to the chimpanzee adenovirus as well as to the spike protein, and people got the 1.5 and the people that got the 2. So we'll be able to approach that. So that's AstraZeneca. It's still a good vaccine, averaging 70. Now, Novavax has a protein particle vaccine, and I haven't seen their data. We were talking about that earlier, Jocelyn and I. But the attraction is that we've had an experience in the past with a protein vaccine, the hepatitis B vaccine. And people who might be uncomfortable with one platform, for example, a foreign virus carrying a code or an mRNA, they may be more likely to accept a protein vaccine. And then just very quickly, you mentioned Johnson & Johnson. They started out with a single dose vaccine. Well, imagine if that were really greatly effective. You would have antibody then in 2 weeks, rather than with a 2-dose, 6 weeks. So you'd have a 4-week advantage. You'd have the first dose, second dose, and then 2 weeks after that for 6 weeks. So that would be very attractive. What Johnson & Johnson is doing now is looking at 2 doses as well as the 1, and we'll have to look forward to seeing what's coming down. So in the pipeline, lots of options, and hopefully, one or more will be attractive to any kind of vaccine reticent population.
Right. Wow. So last, certainly not most important, but very important, is what do you think we can do to help people with hesitancy? We know that we've done surveys all over at different organizations, and we see people having hesitancy in our healthcare workers, 34 to 64%. And Dr. Sifry, what do you think about the hesitancy and what we can do to help?
Yeah, I think that's very interesting. I think it's important to note that really early on, there was much less vaccine hesitancy. Back in May, there was 75% of people in healthcare were wanting a vaccine, and that dipped down to around 50% during the summer. Has now slowly climbed up. I think the more recent polls, it's showing that it's 60s and 70% again, depending on where you're looking at, with like the Gallup poll and some others. And in truth, I think two things are helping that right now. One is the efficacy of these vaccines. It is a lot easier to sell a 95% vaccine than a 50% vaccine. And then the second thing, of course, is what's occurring with this raging pandemic that Dick highlighted with his opening remarks. This is a tragedy that requires a balance of risks and benefits. I think clearly the people on this call are what the benefit are. So when I explore what's going on with hesitancy, I think it's really important to figure out why a person is hesitant. There are different types of hesitancy, and I'll just walk through them a little bit and say how we try to address them. So, one thing is that we understand even in the healthcare environment, there's just people that are anti-vaxxers, vaccine refusists, and those are very difficult people sometimes to really to change their mind. It's worth having that conversation. We need to recognize that there are those very difficult belief systems sometimes. There's a second group that's not quite the same, and those are, I think, people that became very concerned with the things that I talked about, which was the rapidity of the vaccine development. And so that is why I spend a lot of time just talking, to people that I'm seeing in the hallways, very similar to what I talked about here, about the process of vaccine development and the vaccine approval process, showing that it is, the same process that we would do with any other therapeutic, and has undergone the same strict evaluation by independent committees that are not vested, as I think Dr. Tony Fauci once said, they don't have skin in the game as to whether these vaccines are approved or not, and that they've gone through that process with rigor, and they're the people at the highest level of their profession. So I think that's the second part that I do for those people that are very concerned about the rapidity of the vaccine development. There's a third group that I think became concerned about the political overtones with vaccine development. And that becomes also a different conversation as well, and somewhat tied to the talk about how the vaccine went through a normal approval process. But I think I know quite a few providers who became very concerned about the concerns that this accelerated process and other EUA authorizations for different medications in the arena of COVID kind of poisoned the well. Again, I think the size of these studies, the fact that they're performed so well, that they're in the New England Journal and have undergone very strict, exacting protocols and evaluation helps that conversation. And then I think a final thing about vaccine hesitancy is recognizing serious challenges in some of our, particularly persons of color, our communities that have been parts of issues with problems with access to therapies, that they have been exploited in previous clinical studies in the past, most famously Tuskegee. Those are challenging conversations. There are going to be conversations that occur not only within the walls of the hospital that are really going to broach outside the hospital clearly. And Dr. Peak talked about that a little bit. So we need to have an understanding of that belief, of the reluctance of those, some of the people in those communities, and finding the right people that can talk about these messages, that can do so with trust and understanding. And so I think long and short, it really is it's an important conversation that has different levels. And for this group, I think that includes a lot of people who are primary care providers or who are the physicians who have their patients. You're going to be a trusted advisor for those patients. So these are really important conversations I anticipate many of you had for other vaccines throughout all of your professional career. And so that's something to, again, to come back to, is that people are going to look for you for information. And so arming yourself with the education that you need to help with those conversations is really critical.
Sure. And you've all three helped us do that tonight, Dr. Peak, Dr. Wenzel, Dr. Sifri. I'm going to turn this over to our co-moderator, Dr. Wendy Klein, who's been watching the chat, and she's been keeping great track of the questions that have come up. So Dr. Klein, I'm going to let you take it away.
Thank you. We are very short of time, so this is going to be the COVID Q&A version of speed dating, okay? So, Dr. Peak, there's been a question about the plan for vaccinating community providers and staff. How will not the large hospital systems, but how will community providers and staff be vaccinated? Where are they in the tier, and how will they get vaccinated?
Sure. So both some health systems and local health departments are going to be vaccinating non-health system healthcare providers. So it depends on where you live. And yes, so both inpatient and outpatient providers who are caring for COVID patients are in that first group. So local health departments now are meeting with the health systems in their districts, and they're developing plans together about how to get information out to providers that aren't associated with a health system, and to make arrangements for them to get vaccinated.
So the people who are primary care providers who are screening patients for COVID will be eligible to receive vaccines at the local health districts, presumably.
Yes, or a health system. There are also health systems across the state that are going to be vaccinating people who are not part of their health system, so that we have more providers working together to make sure everyone has access quickly.
Great, thank you. Dr. Wenzel, can you comment on the incidence of Bell's palsy that has been reported?
Yeah, well, I can tell you the numbers. After the Pfizer vaccine, it turned out that there were 4 cases of Bell's palsy in vaccine recipients, but none in the control group that got the placebo. It's confusing because while that looks like, well, 4 versus 0, the 4 is actually, when you use a denominator, it works out to be about the background incidence. And so it's a little confusing, but people said, let's look at this. Well, now with Moderna, it's 3 and 1. So 3 in the vaccine recipients and 1. So now we have, if you want to put them together, which is always dangerous, 7 versus 1. But I think it's still too early to know whether there's something that's going to, continue to be an issue, whether it's just a statistical thing. But I think we should pay attention to it seriously because it can be disabling side effect. But it's uncommon. It doesn't appear to be, at this point, higher than the background rate, but we really have to keep an eye on it.
Okay, thank you. Dr. Sifri, people who have had COVID, should they be vaccinated?
The recommendations are that if you've had a history of COVID, you can get the COVID vaccine. There is a recognition that the chance of having a repeat infection within 90 days after an initial, after having COVID clinically is unlikely. We do hear rarely of reinfection or repeat infection following COVID. So it's maybe not as high a priority as other providers. And so if you're taking a look at where somebody stacks up in the queue, it's a reasonable thing to put into the consideration. But recognizing that we don't understand how long-lived immunity is, and that reinfection can occur. And, depending on what a person's place is in sort of the phasing of the system's revaccination within, after clinical COVID, even within 90 days is a consideration.
Thank you. Dr. Peak, we've had some questions from people in community practice with small practices. Can you comment about their capacity to administer the vaccine? Will small practices be able to apply for the vaccine and administer it?
Yes, we have lots of providers have already completed their intent to vaccinate forms, and the form is on our website, so I encourage all providers to consider providing the vaccination. It will be in different phases, though. So at this point, the vaccination is being offered in closed points of dispensing, and we'll have to see what each phase includes. With essential workers, a lot of those are going to be closed pods set up for employees in businesses. So, but certainly when we get to the point of vaccinating the public and also people with certain health conditions, then it's going to be really important for our community providers to assist. Thank you.
There have been a few questions about the mRNA virus. This is for Dr. Wenzel. And the mechanism of action. Dr. Tyson Bell has been kind enough to answer in the chat how that, in fact, the RNA is synthetic and how it's produced. A couple of questions were, can the lipid encapsulated mRNA cross the placenta? Do we know? And can it cross the blood-brain barrier?
The quick answer for me is I don't know. Costa, you may know that. I don't know that.
Yeah, I don't know that either.
Okay, when the mRNA vaccine is administered, it degrades. Does it? Someone asked if it entered mitochondria. My understanding is it does not do that. Correct?
I mean, I think it's worthwhile saying. I mean, I think, and this is what I've heard more commonly is there any evidence that it's trafficked to the sinus tissues or the lungs where it could cause maybe a false positive test. For example, if you're able to produce the mRNA, then produces S protein that's then detected through an antigen test. And that is been said, that's very speculative. We can't rule out the possibility that could occur, but it seems highly unlikely. I think we're a couple orders of degrees of freedom away for it crossing the placenta or the blood-brain barrier.
I agree.
Thank you. Another question is again about vaccinating special populations, people who are HIV positive. Is there any risk to vaccinating them? Dr. Wenzel or Dr. Seafried?
Costi, we already talked about it, so I'll let him continue.
I'll just say that our HIV group, our HIV providers are going to be providing this vaccine. That's their intent once it becomes available. Again, patients with stable HIV were included in the Pfizer study, and there was no issues that were seen in that trial. Also, chronic but stable hepatitis B and hepatitis C as well. So I think, if you were to, if I ask one of my HIV providers, what they will then do is probably have a conversation that would go like, where are they at with their HIV disease? What's their immune system like? What is the local epidemiology of COVID in our community right now? Should I, if they're newly diagnosed, should I get them on active, antiretroviral therapy now and then maybe wait a month, or should I do it right away? And I think that's going to be a clinical decision. And I bet, a year from now, 2 years from now, we'll have maybe, better evidence on exactly how to approach those situations.
Thank you. One quick question. Once vaccinated, can you still carry and spread the virus?
Well, that's a great question. And Pfizer, when they first came out, said this vaccine protects 95% and it protects against severe disease, which makes it a great vaccine. The question is, does it prevent infection? Because if it didn't prevent infection, if you had no symptoms, then maybe that person who was, infected with the wild virus could actually be a carrier and an unrecognized asymptomatic carrier. On the other hand, if it prevented infection and then carriage, that would be phenomenal additional thing for a vaccine. What Moderna said very recently in an addendum was we have some signals that looks like we prevented not only severe infection, severe illness, but also infection itself. Well, we need to see those data a little bit more clearly. And Pfizer said they'll have their readout on the same question probably sometime in the mid-January. It's going to be a very important question because if it only prevents severe disease, I would emphasize people continue to wear your mask, continue to stay distanced, because you could still have people out there who might have gotten no illness but have a virus that's capable of being transmitted. And it's also a good thing to wear a mask and stay distancing as a role model. So there are many reasons not to stop after getting vaccinated.
Thank you so much. In the interest of time, we have to stop. I want to thank the panelists, our moderator, and VDH for supporting these efforts. I'm very grateful to all of you who are attending this panel. I would like to direct you to the VDH vaccine website, which is very current and has all of the CDC, all the latest, it links to CDC recommendations because they have released special considerations and clinical considerations in the last few days regarding many, many aspects of vaccine preparation, distribution, adverse effects, special populations. So I would direct you there. And again, my thanks to everybody. And we need to come to a close. We tried to answer as many questions as we could. I thank you so much.
Thanks, everybody. See you.
Oh, don't forget your feedback. Do your survey so we know what you need. Thank you so much. The link is in the chat.